Triple arthrodesis means, as you already are aware of the fact that arthrodesis means fusion. It is the iatrogenic fusion of the joint. All right. Now, triple means 3 joints are going to be fused. So what are those 3 joints which are going to be fused after performing selective osteotomies? So the names of the joints which are fused are talocalcaneal, talonavicular, and calcaneocuboid. So these are the 3 joints which are fused after performing selective osteotomies. So this is the procedure which is performed in 8 to 10 years of age. Now, what about those children who are presenting to you with the CTEV deformity beyond 10 years of age? Now, in those cases, this triple arthrodesis can also be performed, but serial correction by or gradual correction by Ilizarov method is considered to be a preferred method in order to correct those deformities. So after 10 years of age, it will be subjected to, after 10 years of age, the CTEV deformity will be subjected to Ilizarov correction with the principle of, the principle which is utilized for the correction of the deformity by Ilizarov method is distraction, histio, and osteogenesis. So by distraction, osteogenesis. All of you know that what is Ilizarov and how these Ilizarov is responsible for the correction of the deformity. So there will be a gradual correction of all the deformity by the placement of the Ilizarov after performing the selective osteotomies. And this is by distraction histiogenesis and by distraction osteogenesis, all the deformities are gradually corrected by Ilizarov method. All right. So this is a surgical method beyond 3 years of age. So 3 to 5 years of age, posterior medial soft tissue release. 5 to 8 years of age, the osteotomies which are confined to calcaneum and cuboid junctions are performed. There are various procedures which are involved in this, but all of them are confined. All of them are responsible for performing the osteotomies at that junction in particular. Now, after 8 years of age, that means 8 to 10 years of age, it will be difficult to achieve the correction just by localized osteotomy. So you have to perform variable osteotomies in the foot, and after that you have to fuse these 3 joints, and finally the serial correction achieved by Ilizarov method. So this is how the CTEV related management is all about. Why the possibility of children coming to you at 1 year of age is common, because of a misconception that the child will start walking normally when the child will land up in the age group of walking. That means 1 year of age. So this is a misconception. Later on, the parents, they realize that it was a misconception, and then they come for the management. That is one age group. Another very common age group when the parents come with the neglected CTEV is around 10 to 15 years of age. Why? Because this is the age group of marriage. And they were waiting for this deformity to get corrected automatically. But when the child is about to get married, they wanted to get it corrected. So this is the another age group when the parents come to you with the neglected CTEV. But the incidences of these neglected CTEVs coming to you is getting decreased because more of the deliveries are now getting institutionalized. As a result of which, whenever the pediatrician or a gynecologist, they go on a generalized survey in a case of a child, they used to refer such a child to an orthopedic surgeon for early intervention. That is the reason why Ponseti method is considered to be the most common method today used in the management of the CTEV with the best possible outcome. All right. So the management has changed from surgical to conservative over a period of time. So this is all what you need to remember in case of a CTEV deformity. Now let's have a discussion on the picture. Or let's have a discussion on the image which is being provided to you. We already came to know that how CTEV looks like, and this is how the DB splint, that means Dennis Brown splint, looks like. So Dennis Brown splint is going to have, these are the 2 shoes which are connected by a bar. And how is it different from SFAB? That means the Steenbeek foot abduction brace is going to be discussed when we are going to talk about the individual braces in orthopedics. That is a separate topic in particular. So hopefully you have understood everything related to this very, very important topic, that is CTEV. Now there comes several of the one-liners like, we know that the CTEV deformity might become recurrent, but out of multiple deformities, which one is the most recurrent deformity? Then you have to correct the deformity. Then out of multiple deformity, which one is the most difficult deformity to be treated? So these are selective one-liners which you need to remember. The first one is that most recurrent deformity in CTEV is forefoot adduction. All right, it is the most recurrent deformity. Then most resistant deformity, you know, these two statements are different. Most resistant deformity mean the deformity which is most difficult to treat. It is equinus. Then you will ask that if equinus is most difficult deformity to treat, is there any other way of treating it? Because if it is not, for example, it is not getting corrected. All the other deformities are corrected, but equinus is left. So in resistant equinus, or you can say resistant equinus or untreated failed treatment of equinus, how is it treated by? So resistant equinus is corrected by percutaneous Achilles tendon tenotomy. Now it is not very difficult to understand. Equinus, what will happen? There will be a fixed plantar flexion. So what is the name of the tendon which will be more taut, which will be more contracted? Obviously it is the tendon which is forcing the foot to move into plantar flexion. The name of that tendon is Achilles tendon. That means gastrosoleus tendon. So that tendon has to be sectioned percutaneously just by the insertion of 11 number of blade on the medial side, deviate it laterally and you sectioned it, and the deformity would be automatically corrected. Over a period of time there will be a healing by the fibrous tissue. All right, so that resistant equinus, this is how it is getting corrected. You came to know what the equinus is, you came to know what the inversion is, you came to know what the forefoot adduction, you came to know what the cavus is, and this is how you will identify. Next is, before we talk about the next kind of a question, it is important to have a distinguishing feature of, like, what is calcaneus? I mean, the topic of CTEV is over. Just this terminologies we are discussing, that what is calcaneus? Now, calcaneus is equivalent to fixed dorsiflexion. All right. Fixed dorsiflexion is known as calcaneus. You know, if fixed plantar flexion is known as equinus, then fixed dorsiflexion is known as calcaneus. Simple. Point number 2, the varus is equivalent to inversion, while the valgus is equivalent to eversion of the foot. That means if the foot is said to be in inversion, the foot is said to be in varus. While the foot is said to be in eversion, the foot is said to be in valgus, or the ankle is said to be in valgus. Now, what are the reasons for that? You know, you already came to know calcaneus means simple dorsiflexion, fixed dorsiflexion. But what are varus and valgus, and how inversion and eversion are responsible for influencing this varus and valgus deformities at the level of ankle? Just try to have a basic understanding of this. Now, imagine this is the foot on which you are standing. You know, this is the normal alignment of the distal end of the tibia, normal alignment of the distal end of the fibula, and this is the talar bone. So when everything is normal, or you are standing with the neutral position of the foot, imagine you are standing with the neutral position of the foot, then the weight bearing axis is falling exactly in the center of the talus. This is how the weight bearing axis is falling exactly in the center of the talus. But what will happen if you stand with the inverted foot? Imagine if you are positioning yourself. Imagine if you are standing on the inverted foot like this. So this will be the distal end of the tibia, this is distal end of the fibula, and this will be the talar bone. Now the talar bone, when you are standing in the inverted foot, the talar bone will be deviated more laterally. So the weight bearing axis is not going to be a straight line. The weight bearing axis will be creating an angle, and this angle will be creating an apex, which will be pointing towards the lateral aspect. So if the apex is pointing laterally, it is known as varus. Understood? So this is how inversion of the foot is equivalent with the varus deformity of the ankle. Similarly, when you stand with the everted foot, then the weight bearing axis is not going to be exactly a straight line. It will be creating an angle, the angle with the apex pointing medially, and that would be coined as valgus. So eversion is equivalent to valgus, while inversion is equivalent to varus. This is how it is important for us to understand. Now it will become much easier for you to identify or relate the term that is CTEV, congenital talipes equinovarus. Now, you know, CTEV, congenitally present deformity, where tally is related to equinus. Now you can understand that how talus and equinus are related. And second, pes is related to varus, or the foot is related to varus, and this inversion of the foot is related with the varus deformity. And this is how the term was coined, that is CTEV. Hopefully you have understood everything related to this particular topic. Now, if I show you one picture, that if you see this picture and you have to identify what is the name of the deformity, and if I give you four different options, like one of the option is with this kind of a picture, if 4 different options are provided to you that name the deformity the child is presenting with, one of the option is calcaneovarus, other one is calcaneovalgus, the third one is equinovarus, and the fourth one is equinovalgus. So these are the 4 options you are provided with, and you have to mark the correct answer out of these 4. Which one is the correct answer for this particular deformity? Now, if you can very clearly observe that here the foot is in dorsiflexion, so it is calcaneus deformity. Second, you have to identify whether it is in inversion or eversion. So the foot is in eversion. That means eversion is going to be linked with the valgus. So you combine both of them and you get the correct answer, that is calcaneovalgus deformity. So be ready for these kind of the questions in your future examinations, where they will give you a picture of foot itself, and then they will ask you what is the name of the deformity the child is suffering from. Similarly, you know, one of the deformities or one of the condition which is very closely related with the CTEV is a rocker bottom foot. You know what happens in case of rocker bottom foot? Just by putting a star, you can write it down, this entire topic. Rocker bottom foot, it is actually the congenital vertical talus. All right, rocker bottom foot or congenital vertical talus. Now, what exactly it is? You know what happens in congenital vertical talus deformity? The foot plantar surface or plantar arch is lost. It is either flat or it is either convex. So one of the deformity is either convex or flat plantar surface of the foot. Then apart from this, there will be calcaneus. Now all of you know what the calcaneus deformity is, and there will be, to some extent, there will be eversion of the foot. All right, so there will be valgus deformity. So these are the 3 deformities which are present in a rocker bottom foot. That means in case of a congenital vertical talus or flat foot. All right, one and the same thing. So with this, we have compiled all the deformities of the foot. You know, the mainstay of these deformity remains the CTEV, and you have to remember at least the identification and the management protocol of the CTEV deformity. All right, so the next very important topic or very relevant topic is DDH. That means developmental dysplasia of hip. So if we go with the full form, it is developmental dysplasia of hip. Now the same condition, that means DDH, was previously coined as, previously it was termed as, you know, the previous terminology, it was CDH, that means congenital dislocation of hip joint. Now there are reasons why there was a change in this terminology from congenital dislocation of hip to developmental dysplasia of hip. Now before we talk about why there is a change in the term, it is important to have a basic understanding of what actually is the primary pathology related to this developmental dysplasia. So what is the primary abnormality or the primary pathology? It is acetabular dysplasia. Now what do you mean by the term acetabular dysplasia? Simply, that means acetabulum is not developed normally in its shape and contour. Just try to understand. Imagine this is the hip joint. This is the acetabulum, this is head of the femur. So the shape and size of the acetabulum has to be complementary to the shape and size of the head of the femur. Now imagine if the child is born with the abnormally created acetabulum. For example, the shallower kind of the acetabulum. Shallow acetabulum means, imagine if the child is born with this kind of acetabulum, so it will be difficult for this acetabulum to hold the head of the femur within its confine, as a result of which it will get dislocated out of the